Hi, welcome to another in our series of tutorials on various topics. Today's topic will be endometrial adenocarcinomas and their precursors. It'll be the first of two parts on this topic, and I hope that it will help you to see some of the varieties and differences between these entities. I want to thank my collaborator, Dr. Sherry Irwin, one of our outstanding trainees, who's helped me to prepare this program. So the first thing to be aware of course, is the precursor and mimics of endometrial carcinoma. And these fall into the category of hyperplasias. Um, there's a long and storied history to the classification of these entities, but we've devolved to essentially a two-tiered system, which puts all benign hyperplasias in one category and the pre-malignant higher risk hyperplasias or endometrioid intraepithelial neoplasia, EIN, into the other category. Uh, and then, of course, drawing the boundaries between these so that you can reliably distinguish them is part of the art of pathology. And it is a bit of an art as well as science. There are criteria which we'll go through, but you have to take a degree of experience and practice at doing it to be confident in more cases. And there always will be some differences of opinion between what is hyperplasia and what is carcinoma, what is atypical hyperplasia and what is not atypical hyperplasia. But in general, the wise sages of our field have tried to develop fairly simple criteria that can be easily applied and help in making that distinction. So, non-atypical hyperplasia is generally a disease of older adults, adult women. There are some of the same risk factors that are associated with non-atypical hyperplasia that are associated with preneoplastic and malignant diseases of the endometrium. Of course, these can involve endometriosis as well as the endometrium itself, and so can be identified in the stomach, in the ovary and intra-abdominal and other locations as well. Uh, there is still a small risk in these patients that, given this milieu of hyperestrogenism, that they will progress to either atypical hyperplasia or endometrioid adenocarcinoma. The categories to be considering here, things to be considering, of course, are the age. In general, the gland to stroma ratio in all hyperplasias is increased. 3 to 1 is a recommended cutoff, but certainly anytime it's 1 to 1, you want to be starting to think about that possibility. And certainly when it's 2 to 1, even more so. There will be a degree of architectural complexity, which you can see here. There's some branching and forking in these endometrial glands. But the presence of cytologic atypia, in other words, a distinction between these hyperplastic glands and the background, more normal glands, is nil. And that's the important thing, is that the comparison of the glands in this setting with the other glands in the patient's endometrium is very critical. I didn't include a digital slide with a lot of good experience, but this may be helpful for us to think about an area like this: mildly increased gland to stroma ratio. You can see that, and then as we look at the cytology on these glands, they look very, very similar. They don't look at all atypical. We can look around a little further on this here and perhaps see a few other areas where there may be some complexity, such as right here. But again, these have a degree of secretion, and the glands do not show any atypia. So you can explore this gland, this sample, and see what other findings you may be able to identify. But in general, those are the features. Now, a lot of this is fairly normal endometrium. There's been a mixture of some decidual changes, as you can see here, along with other areas that look more secretory. But these are the sorts of things that you see. Sometimes in these typical endometrial hyperplasias, it will be just a very secretory pattern. Sometimes it is actually non-hormonally responsive, and that is what gives it the impression of being hyperplasia. So, although this is not a great example, and we had difficulty finding good examples of such, at least gives you an idea of some of the vagaries that can be encountered in these kinds of settings. So sometimes endometrial basalis may be confused as well with hyperplasia, and that's a valued pitfall to avoid. Here's maybe the more classic area. This maybe is part of a polyp or something of that sort. You may see a little bit of squamous metaplasia, but here again, there's not a high degree of atypia in any of these glands. The nuclei are generally not hyperchromatic. They don't have prominent nucleoli. So this is kind of the nice example here of what you would expect to see in a non-atypical hyperplasia, in this case associated with maybe some polypoid changes and squamous morule metaplasia. When we come to the question of atypical hyperplasia or EIN, these patients are again in the same age group, but these, as you can see, have a higher risk of developing carcinoma over the ensuing years. And in many cases, depending on the observer, these will have concurrent endometrial carcinoma on further evaluation. So in other words, we see EIN on a biopsy, but then we do a hysterectomy, and lo and behold, there's an early invasive carcinoma that is present. In this situation, it's similar. You have a high gland-to-stroma ratio. The cytologic atypia, however, is present. There's a distinctive difference between a so-called normal gland, as you might see here, and these cells. It's a difference that even your 5-year-old could tell was different. They may not be able to describe it, but there is a distinct difference. And that difference is usually hyperchromasia, a little bit less nuclear polarity, nuclear enlargement. So they begin to look bluer, and you may have more of the metaplastic changes. Additionally, there's a size criterion that is important for this, that things that are less than 1 millimeter, while we might comment and call them atypical glandular proliferation, we would not classify that as EIN. It would not have the same level of risk as EIN. So here's an example. As we can see at lower magnification, there are some clustered atypical glands here in a few areas. I'll just sort of pan around the slide to see where maybe the most high density area is. Maybe an area like this is beginning to get higher density, and then you see some enlarged atypical glands here. And as we look at these nuclei and the glands themselves, you can see there's a little bit more hyperchromasia when you compare it to some of the more normal tissue around. Let's look a little further and see if we can find a more fully developed area. So here, these are the benign glands. You see the nice small contours, basal-oriented nuclei, and so forth. And then we develop areas that are a little bit more atypical. Such as here, a little higher gland-to-stroma ratio, variable nuclear atypia, a little bit more stratification, crowding of these nuclei. It's a subtle difference, but there is a definite difference here. Still, you'll find mitotic figures in this situation and a size here of greater than a millimeter in that location. So not a florid example, not a case where you're going to be highly concerned about the boundary between this and neoplasia, but one where you can definitely discern a difference, see the architectural changes. Here's a little bit of metaplasia going on as well. Now notice here we have an area where the gland-to-stroma ratio is not significantly altered, but where we have other areas where we've identified that, we would still include this as a portion of that change. Here's another example. Again, this one a little easier. You can see here the gland-to-stroma ratio is quite high, and even we're beginning to get some areas that may begin to make us worried about near solid growth. So here again, we see more enlarged glands, more closely spaced, some approaching a infamous back-to-back arrangement, and the nuclear atypia is more pronounced. In this case, it actually was a little bit difficult to identify benign underlying morphology, benign background glands. So while we might have chosen a few glands like this as being somewhat atrophic, that's probably about as good as we're going to get. And this is helpful because you can see these glands are very low cuboidal to columnar type glands with very little active appearance. Whereas if we look over here at the more classically hyperplastic area, we see these cells are enlarged. The nuclei is occupying the bulk of the space. The arrangement is altered, and the secretion in the lumen, of course, is more evidence of activity. So this is a nice example, fairly easily diagnosed of atypical endometrial hyperplasia, or EIN. And here's a third example, just to give you a little bit more chance to practice identifying and featuring identifying the features that we've talked about. Here you can see high gland-to-stroma ratio, variable shapes and sizes, and as you can see, again, sort of nuclear enlargement, a degree of hyperchromasia, active secretion, in this case a little bit bloody, corresponding to the presentation of vaginal bleeding, and pretty simple. The difficulty with a case like this would be making sure that you did not have a definitely identifiable endometrial carcinoma. And as we begin to talk about the criteria for that differentiation, there are a couple of things that come to mind. One is any degree of solid growth should make you be more concerned about endometrial carcinoma. Additionally, intraluminal necrosis or areas of necrosis, while not entirely specific, are certainly more suggestive of endometrial carcinoma over endometrial hyperplasia. And then finally, high degrees of nuclear atypia, grade 3 nuclei, and so forth should certainly raise a greater consideration for endometrial adenocarcinoma. And you can see here these cells, tall, big cells, but fairly bland, low-grade appearing nuclei. Another example, I'm going to let you explore this one on your own. Another example, again, to give you some practice in this differentiation. Find the areas here which would qualify. And yes, the blue dot will help you a little bit. Here you can see this area where there's an increase in gland-to-stroma ratio. You've got some abnormal background glands, but compared to the more normal glands elsewhere, such as over here and over here, there would be a distinguishing characteristic. And the size certainly falls into that category. This is a patient who obviously had a hysterectomy, and you have sectioned the endometrium in its totality to evaluate the polyps and the presence of the glandular atypia here. Some people have used immunohistochemical staining as an adjunct, and here's an example of loss of uh, um, PAX2, which is sometimes a marker for that uh, feature. Not totally specific, but can be helpful in sort of borderline cases. The other marker that we use is P10, and here's an example of that, showing areas where you have gotten very strong staining with P10. Now notice here that it's almost all the glands, and that's an indication that sometimes the molecular changes are more widespread than are the immunohistochemical stains. Here's the area of concern. Well, no, I don't think this is it. A degree of loss here. So this would be the normal area here, and this is the abnormal staining tissues here are the ones that you see. So that's kind of a nice contrast. So even though we may not morphologically have the features in some of these glands that would say atypical hyperplasia, you can find sometimes the molecular features in those tissues as well. So let's go on and talk about endometrial hyperplasia. Oh, excuse me. Management in these cases usually is going to involve surgical management. In younger patients or patients desiring to retain fertility, you're going to get patients being treated with progestational agents, oftentimes a intrauterine device that secretes hormone, and that will result in decidual changes in the stroma, and it will also tend to damp down the nuclear atypia. What it doesn't tend to damp down or to diminish is the degree of hyperplasia. There's still some architectural atypia, and we've done a video on that topic as well. So that's an important consideration, is to recognize that areas of abnormal architecture, when present in a decidualized endometrium that's being treated for EIN, probably represents residual disease. And here's a nice example, I believe, of this, where here's a degree of architectural complexity still remaining in this treated tissue, whereas the other more benign areas have here the decidual change and very atrophic glandular features. So when you have areas that persist with any degree of architectural complexity, you should be quite concerned about the possibility that there is still some residual disease, because the normal response would be for the stroma to predominate and there to not be any degree of architectural complexity remaining. So even bland areas like this that may look very bland may represent residual EIN. Now, that's not to say that every treatment failure is going to result in immediate surgery. They usually monitor these patients at fairly frequent intervals. And so let's see if we've got other stuff here. So that additional monitoring of these patients will be part of the process. It's not until they are still failing at 9 months to a year and a half, that they will then be pressuring for surgical removal. So I may have another example of this disorder. No, I don't. So EIN can also sometimes have papillary proliferations that look almost like serous carcinoma. These papillae within otherwise normal endometrial glands or low-grade endometrial glands are not serous carcinoma. They do not have the TP53 mutation, but there is still some degree of risk associated with these. All right. So, endometrial adenocarcinoma most commonly most commonly fits into the low-grade type of lesions, the FIGO grades 1 and 2. And these show, as we've seen in EIN, crowded glands with cytologic atypia. These are usually peri and postmenopausal patients in their 50s and 60s, and they present usually with bleeding, some degree of bloating or mass effect, depending on the degree of invasive tumor. They usually have estrogenic stimulus going on, either due to a concomitant estrogen-producing neoplasm, or most commonly due to a prolonged period of hyperestrogenism related to either obesity or acyclic cycles. We grade these tumors into grades 1 and 2 based on the cut point of 5% of solid growth, non-squamous, and less than 50%. Once they reach 50% or have a high degree of nuclear atypia, then we move those into grade 3. The behavior corresponding somewhat with that. Although typically these lower grade 1 and 2 have fairly similar outcomes. So let's take a look at an example. And here you can see a high degree of architectural complexity. You can also appreciate the hyperchromasia that's associated with this neoplasm. And I guess we can't see really well at this because of the high degree of staining here, the nuclear atypia, but the NC ratio is significantly altered. Now, the distinction between this and endometrial intraepithelial neoplasia, I've mentioned necrosis. I don't see that here, but just the extent and confluence of the growth here should probably be enough to persuade you that it's going to be carcinoma. You may still have some areas of normal or atrophic endometrium remaining. Here you can see for comparison how small these glands are. And that tells you, of course, that the patient is postmenopausal and that this process has arisen in that setting. Usually you will not see definite features of invasion in the curettage, although sometimes you may see evidence of dystrophy and so forth. But any degree of stromal presence in these lesions should be carefully investigated. There may be areas of dedifferentiation. There may be areas of sarcomatous transformation. In addition, there is a variant which has spindled and chondroid elements and may have other heterologous elements in the presence of still a group 1, a grade 1 tumor. Additionally, endometrioid carcinomas can give you mucinous metaplasia in cases. So awareness of that feature is also important. Here's another example. Here we can see, again, closely spaced glands, very enlarged cells. And notice that in some of these lumina, we're beginning to get this sort of cellular necrotic features in a few of the glandular spaces. Because mixed carcinomas can occur, you certainly want to investigate any areas that have a clear cell change to exclude the possibility of clear cell carcinoma. Here you can again see this sort of tumor diathesis within the lumen, blood mixed with cellular debris, and so forth. All very helpful in defining this as endometrioid adenocarcinoma rather than EIN. Here's the areas of more solid type growth. And by solid, we don't always mean that there's no glandular evidence left. It's just that the gland lumina has diminished to the point that it looks nearly solid. There's no open space. As you see here, and some of these glands have nice open spaces, but glands like this would be more solid type growth. And it doesn't take a whole lot of that kind of pattern to move it into grade 2. Another example, here in a hysterectomy specimen, again, a case which we've talked about in some detail before. Here you see the glands are not entirely back to back. There is a little bit of intervening stroma, but again, we have the tumor diathesis in the lumen, and we have areas of morular metaplasia. Now, this has the appearance of being an invasive tumor, but in fact, as we look at each of these areas, we will see that there are oftentimes a few residual benign glands, such as you see right here. And you can see the contrast between that associated with stroma. So this is actually endometrial adenocarcinoma that has extended down into adenomyosis, very deep, very close to the serosa, but is not, frankly, invasive. So anytime you can see things like that, you need to look and see, okay, do we have benign glands associated with this? Do we have benign stroma? And in this case, we do. Now, the same type of process, I suppose, theoretically could occur with EIN. And so you could have EIN that looks very invasive, but is actually just involving severe adenomyosis, as is the case here. So this case should be still staged as a T1A because this is all adenomyosis rather than a T1B with nearly full thickness invasive disease. And again, even this little cluster here has this benign gland in contrast to this more neoplastic gland, thus defining it as adenomyosis. Here's another example. We're going to skip over that and let you come back and study these. Now, the link to these digital slides will be available in the description of the video, allowing you to come back and look. So here again, another example where here it looks like this has got nice stroma with this. This is adenomyosis, whereas we've got maybe an area of carcinoma up here superficially. Now, this is an example of a higher grade tumor. As you can see here, there's very little glandular growth. And so even at low magnification, I would say this is most likely going to be a grade 3 tumor. In grade 3 tumors, you need to be very cognizant of the potential for dedifferentiation. So looking for areas of low-grade tumors such as this might lead you to think about this as being dedifferentiation. And that's an important consideration. It changes the outcome and prognosis significantly. And so entertaining that possibility is important, particularly if you see differences in the immunoprofiles between these areas. And we'll talk about that a little bit more in the next video. So I think we're going to stop at this stage and come back with part 2, beginning with this concept of mucinous metaplasia, differentiation in endometrial tumors, as we begin to talk about some of the variants of endometrioid adenocarcinoma and about the other tumors, the serous, the clear cells, and so forth that can occur in this location. So thank you so much for joining me for this brief introduction to grading and typing endometrial adenocarcinoma as well as its precursors. And we hope to see you on the next installment on this video.